They told us the cure was complicated. That disease was nature's way of reminding us we're fragile. That chronic illness, once it arrives, becomes a lifelong companion, manageable but never erasable. The narrative is familiar, repeated endlessly by white coats, glossy pamphlets, and primetime ads. Yet buried beneath this polished reassurance lies something else. A calculated system. One that profits not from health, but from perpetual sickness. In the past 50 years, chronic diseases have exploded. Heart disease, diabetes, autoimmune disorders, neurodegenerative conditions. Not in isolated regions, but globally. 1 in 2 adults in the United States lives with a chronic condition. That is not a public health failure. That is a business model. To understand how deeply embedded this model is, we need to start with how modern medicine defines treatment. In medical school, the emphasis on pharmacological management is relentless. The doctrine is clear: identify symptoms, prescribe a drug, monitor side effects, adjust dosage, repeat. Rarely is there a search for reversal. Rarer still, a cure. Why? Because cures are terminal. They end the transaction. A cured patient is a lost customer, but a managed patient is a lifelong subscription. Consider insulin. It was first isolated over a century ago. The scientists who discovered it sold the patent for $1 because they believed no one should profit from it. Today, insulin generates over $20 billion annually for pharmaceutical companies. The drug hasn't changed significantly. The delivery systems have. Prices have soared. Meanwhile, research into reversing type 2 diabetes, a possibility already demonstrated through controlled trials and lifestyle interventions, remains underfunded and buried beneath commercial noise. This is not an isolated example. Statins, antidepressants, proton pump inhibitors, all drugs designed not to cure, but to sustain, and in sustaining, to profit. When symptoms are controlled but causes remain unaddressed, the illusion of health is maintained just long enough for dependence to set in. This isn't negligence, it's design. The power of this system rests in its invisibility. Patients believe they're being helped. Doctors believe they're helping. And somewhere, behind the curtain, shareholders read quarterly reports with satisfaction. The machinery functions best when no one questions its structure. But the cracks are visible. In the growing resistance to standard treatments, in the quiet rise of independent researchers, silenced or discredited, in therapies that disappear from journals without explanation. Some of them tried to speak. Most were discredited before they could finish a sentence. When a potential cure emerges that threatens a profitable treatment stream, it rarely reaches the surface untouched. The playbook is consistent. First, marginalize the source. If the discovery comes from outside the pharmaceutical complex, an independent lab, a university researcher, even a whistleblowing clinician, it is labeled anecdotal, premature, or methodologically flawed. Journals refuse publication, grant committees withdraw funding, and media coverage quietly vanishes. The cure does not disappear, it is erased. In 1971, President Nixon declared a war on cancer, and billions were funneled into research. Yet over 50 years later, with trillions spent globally, the most aggressive forms of cancer remain unyielding. Chemotherapy, radiation, and surgical interventions, despite their toxicity, remain the dominant approach. But alternative pathways, including metabolic therapies and immune modulation, have shown promise in early trials. Many never made it past phase 1, not due to inefficacy, but because they couldn't be patented. The system does not reward healing. It rewards intellectual property. Drugs that can be owned, controlled, and monetized are prioritized. Natural compounds, turmeric, berberine, cannabis derivatives, often show multifaceted therapeutic potential. but their paths to market are obstructed because they cannot be monopolized. The question is no longer scientific, it is economic. Behind peer-reviewed journals lie powerful gatekeepers, editorial boards with deep ties to pharmaceutical funding, research institutions reliant on grants that come with conditions. If a proposed study threatens to disrupt existing treatment paradigms, it risks being buried under bureaucracy. In 2009, an internal memo from a major pharmaceutical firm detailed a list of inconvenient findings and outlined suppression strategies. The memo never reached court. It was quietly settled, sealed. Those who persist are watched, not in the theatrical sense of surveillance, but in real procedural ways. Career paths stall. Labs lose accreditation. Anonymous threats arrive. A professor at a European university who claimed to have reversed multiple sclerosis symptoms in a small cohort lost his funding 2 months after publication. His institution cited data irregularities. None were publicly disclosed. We are told this is science, that only what passes rigorous review can be trusted. But the review process itself is deeply compromised. It has become a filter not for truth, but for compatibility with the existing narrative, with existing revenue streams. There are countless cures buried not by failure, but by success that threaten the wrong portfolios. And in some cases, the cure was found, just not for us. If you want to stop being manipulated every day without even realizing it, I invite you to get the Banned Protocol book. You'll learn how to identify the hidden systems controlling your health and mind. In just a few weeks, you'll start seeing what others can't. I've already heard people say, after reading it, I can't walk into a grocery store the same way. Check the pinned comment below. The pharmaceutical industry is not a health service. It is a global power structure interwoven with governments, regulatory agencies, and financial markets. Its influence runs far beyond the clinic. It dictates policy, it shapes education, it funds regulators, and in many cases, it decides what counts as disease and what doesn't. Consider the World Health Organization, portrayed as the ultimate authority in public health. It receives nearly $1 billion annually in voluntary donations, over 80% of which are earmarked by the donors. Many of these donors are pharmaceutical giants or their proxies in the philanthropic sector. This means that even at the highest level, public health policy is not directed by epidemiological necessity, but by corporate agenda. When definitions of illness are determined by financial interest, the threshold for diagnosis begins to shift. New disorders are coined. Existing conditions are redefined. Mild symptoms are medicalized. The Diagnostic and Statistical Manual of Mental Disorders, revised regularly, has seen an exponential growth in classifiable syndromes. Each new entry expands the pharmaceutical market, not by chance, by design. Meanwhile, the Food and Drug Administration in the United States, the European Medicines Agency, and their counterparts elsewhere are riddled with conflicts of interest. Senior officials frequently rotate through executive positions in pharmaceutical companies, returning later to regulatory posts. This revolving door ensures that oversight never threatens the core business model. In internal audits, several regulators have been shown to fast-track drugs with insufficient data, relying on studies funded, conducted, and interpreted by the very companies seeking approval. This is not oversight, it is collusion. The power extends into academia. Leading medical journals have published ghost-written articles penned by pharmaceutical companies and signed off by credentialed academics in exchange for compensation or favor. Textbooks used in medical schools are frequently funded by drug companies. The result? Generations of doctors trained to prescribe, not to question. And still, for the patient, The illusion persists that if a cure existed, surely someone would tell us. But silence is not absence. Suppression is not failure. In restricted forums, at underground symposiums, in redacted patent applications and anonymous leaks, whispers of effective treatments continue to surface. Some of these are already in use. Off-label, unapproved, quietly administered by those who still remember what medicine was supposed to be. One such protocol was traced back to a military research division, originally designed not for therapy but for enhancement. It showed radical cellular regeneration, far beyond any approved treatment. It was classified. If this stays online, it means they missed it. There is a deeper reason the cure must remain hidden. It is not only about profits, it is about control. A chronically ill population is not just a revenue stream. It is a manageable, predictable system. Individuals dependent on continuous medication become tethered, not only biologically but economically and psychologically. Their energy is spent navigating symptoms, scheduling appointments, negotiating insurance claims, adjusting dosages. They are too distracted to question the structure itself. Illness becomes identity. It infiltrates language, reshapes expectations. Entire communities are formed not around healing, but around enduring. Suffering is normalized, sometimes romanticized. The possibility of total recovery is quietly withdrawn from the collective imagination. What remains is a culture of compliance. People do not rebel when they are convinced their pain is unchangeable. But this was not always the case. Ancient systems of medicine, from Ayurvedic to traditional Chinese, from indigenous knowledge to early naturopathy, emphasized balance, regeneration, and root cause resolution. These systems were not perfect, but they held one dangerous idea in common: that the human body is capable of healing, that restoration is not impossible, that dependency is not inevitable. It is no coincidence that these traditions have been dismissed, banned, or ridiculed. When a worldview threatens the infrastructure of control, it must be dismantled, not with arguments, but with ridicule. And when ridicule fails, with regulation. Entire modalities are outlawed. Practitioners are arrested. Healing becomes a black market. Every decade, a new health crisis emerges. Each time the answer is the same: more drugs, more surveillance, more compliance. What is never suggested is the dismantling of the system that allowed the disease to flourish in the first place. What is never funded is the exploration of why these illnesses rise in lockstep with modernization. There are regions in the world where these diseases remain rare, not due to lack of access, but due to lack of interference. Diets that have not been industrialized, lifestyles not yet colonized by the rhythms of consumption. These communities are studied not to emulate, but to extract biomarkers, harvest genetic data, and eventually to assimilate. The goal is not preservation, it is standardization. And still something resists. In quiet corners of forgotten clinics, in unregulated zones of the internet, in encrypted data repositories and anonymous case studies, fragments of the cure remain, not as myth, as suppressed data, as abandoned patents, as lives that recovered when they were not supposed to. Save this while you still can. Not everything was meant to be seen. But here it is.